Hello, everyone. Welcome to the session on research and policies on the horizon. My name is Richard Knight, and I will serve as moderator for this exciting session. During this session, we will discuss 4 or 5 topics that are very current and relevant to the kidney patient community. The first topic we're going to discuss is the use of eGFR. Is it a relevant measure? To discuss this topic, we have Dr. Gadegbeku, who is a founding member of the Diversity and Inclusion Committee and a member of the Public Policy Board for the American Society of Nephrology. She is also a member of the National Kidney Foundation, American Society of Nephrology Task Force on reassessing the inclusion of race in diagnosing kidney disease. This is a very talked about topic, and I couldn't think of a better person to provide some insights and balance to the subject. Dr. Gadegbeku, the mic is yours.
Thank you, Richard. It's such a pleasure to be here again for your Policy Summit, and I'm excited that this is the 4th annual Policy Summit that you're having. Today, I'm happy to talk about much active discussion that's been going on with race and estimated kidney function or estimated GFR. So obviously, assessment of glomerular filtration rate or kidney function is really important in medicine. It's important for several reasons. First, the clinical practice. It's important for detection and management of chronic kidney disease, but it goes beyond this. It's important for everyone in that it's important for knowing how guiding drug dosing and evaluation of people who develop kidney injury, acute kidney failure, and recovery. So it definitely goes beyond patients who suffer from kidney disease. It's also important for advancing our research. We need therapeutic advancements for kidney disease, but beyond this, we also need to be able to develop drugs that are safe. For instance, you'd like to have a cancer drug that has no injury to the kidney as a better cancer drug than one that does. So it's important for research, and as well, it's important from a public health standpoint to understand how kidney disease is changing over time, the number of people, for us to guide health policies that best protect humans. So we have to start from the beginning, and understanding the properties that make an ideal marker for kidney function are really germane to this issue. So the kidney, as depicted here, and as one knows, has a number of glomeruli, a million of these filtering units that filter the blood every second of every day. And in order to be able to measure that function, we need to have something that is produced at a constant rate, that is not protein bound, not metabolized or broken down, freely filtered, not secreted, and not absorbed. That would make the perfect marker of kidney function. So unfortunately, we don't have that perfect marker of kidney function that is available to us on an everyday. Measurement of kidney function, true GFR, is quite complicated. What we do is we use exogenous substances, or substances are not made, that we can put in the body and then measure them over time. The gold standard measurement is called inulin, which is not often used anymore. Mostly we use these radioactive tracers that allow us to measure the amount of radioactivity that is eliminated over time. And they're linked to iothalamate, EDTA, or DTPA. Those are just some substances that we link these isotopes to. And the way it's measured is it requires multiple timed measurements and measuring blood and urine over hours. So as you can imagine, this is not really clinically feasible, but is often used for research purposes when we really need to know the exact measured GFR, and it's been used to calculate these estimating equations for GFR. So what we do use is not an ideal marker, and it's serum creatinine that many of you know about. It is an endogenous marker, meaning that it is made by the body, so that we don't have to add something to get this GFR measurement. But it is not ideal in that it is not constantly produced. It is actually differs over age, if there's a loss of limb, and based on diet. It does satisfy the several properties of not being protein bound or broken down, and is freely filtered, but is also secreted, so to a range of 10 to 15%, and it's variable in different people and variable from day to day. It is also not absorbed. However, it is very easy to measure and can be widely measured, and as pointed out here with the STAT sensor, it can be even measured at the point of care. However, the problem with serum creatinine, because it is not perfect biomarker, one of the main issues is that it is not very sensitive, particularly at high measurements of GFR. Here I have two graphs that show inulin clearance over the range of 0 to 120 and the serum creatinine measurement. And as you can see, from 120 to 60, there's very little change in serum creatinine. And so when you're thinking about a marker that's going to help you to detect kidney disease early and changes in kidney function, it is not very good. Therefore, equations were generated to take the serum creatinine, which is an easily measured marker, and extrapolate to kidney function measure, or GFR. And I just like, in order to really understand the issues at hand, I'd like to take you through the timeline of development of these equations that has led us to where we are today. So in 1976, the Cockcroft-Gault equation was the first estimating equation of GFR. And it's very notable that it was built with 249 white men. And that became the standard measurement of kidney function. Did not have women. The measurement for women was something that was calculated and obviously did not have any other race included. In 1999, nearly 20 years later, we had an improvement of this measure to the MDRD equation, which was generated from a study of kidney disease, had now included white women and 12% Blacks in the population, a much larger population, but was designed for kidney disease. There was some concern that with a very homogeneous population, that it may not be as useful in the Black population. And therefore, when the African American study of kidney disease was performed, they decided to again measure GFR using these research methods, and actually validated the MDRD equation as being accurate in self-reported Black individuals. However, these equations were limited to patients with CKD. And so in 2009, there was an advancement to actually be able to use an equation that measures throughout the length of kidney function, and also to increase the number of patients, diversity in the population. And that's when CKD-EPI came about. Both of these MDRD and CKD-EPI equations had a race modifying characteristic. Then CKD-EPI was actually created with Cystatin C, which did not have the race modifier involved, and created a lot of initial excitement. However, being that this was an expensive measure, really did not catch fire. And here we are today, 2017 to 2020, in which the issue of having race in a calculation was questioned. So going through each of these equations, Cockcroft-Gault, as I said, was used to measure creatinine clearance. Therefore, it is inherently an overestimation of actual GFR because the creatinine is secreted. Again, it was developed in a small white male population, and therefore the extrapolation to females was simply a calculation that had not been proven. Unfortunately, because it was done at the time of many medications were approved, it still has become, for most part, the standard for medication dosing. The MDRD equation, quite an advancement developed in CKD, had been tested in several CKD populations, was a much, much more complex equation and had the race modifier characteristic in there because of the population that it derived this in was found to have, when compared to GFR, and we'll talk about this more, the need for that for accuracy. The one thing about both MDRD and Cockcroft-Gault, but mainly focusing on the MDRD equation, because it was derived in patients that had CKD, it was not really feasible or accurate in patients beyond a GFR of 60 mils per minute. As you can see, each of these represent an individual patient who had both a measured GFR on this axis and the estimating equation. And therefore, it is really based on to be used in patients with kidney disease below 60 mils per minute. The CKD epi equation was an advancement of this in that it took GFR measurements from multiple studies in its development, 10 studies across the range of GFR, so that could be used in every type of patient, not just CKD, and also validated in 16 more studies using many, many more patients, a much more complicated equation than the MDRD equation, but had the advantage of being able to be used across the span of GFR. So then came Cystatin C, a newer marker, and the benefits of this marker is that it was not dependent upon muscle mass or a diet, and is not secreted. So in that sense, it was a better marker. It's derived from nucleated cells. It does have some things that influence it, like steroids and thyroid function. But the real limitation here was that it was expensive, and all centers and institutions weren't able to have it, and so therefore not very feasible. And that's why we haven't had serum creatinine still based equations became pretty much standard. So what about race in any measure for clinical medicine, but specifically with the measure of CKD? So first of all, race is not a biological attribute. It is a man-made social construct. And there lies a lot of problems, namely race in precise proxy for ancestry, which is genetics. And often race is assumed in the clinical setting, making it even more inaccurate and less able to be less viable as linked to biological attributes. In many of these reports, and all of them that have measured GFR, except there's some question in MDRD, these were based on self-report, which is not always the case in the clinical setting. A major limitation of this is we do not live in a black-white world, right? We have multiple races, and we have multiracial individuals, and therefore these equations don't include or account for that complexity of the diversity within our society. And another major issue is we all know that CKD, that there's significant health disparities within CKD. And so it's very important that we get this right in a population that may have increased susceptibility towards kidney problems. So going back to this graph of serum creatinine on one axis and GFR measured by the research method inulin clearance, it was noted very early on that there was, at a given GFR in a measured way, that there was a significant difference between the actual blood level of serum creatinine in someone who was white or black in early studies. This was also supported by National Health and Nutrition Examination Surveys and Haynes, which is reflective of general population, in which the serum creatinine in the general population was slightly higher among Black and white men and women in this population, but did not account for measured GFR. Very interesting study came more recently looking at genetics or African ancestry in serum creatinine. This is a quite fascinating study that includes African Americans and Hispanics, of which there is a wide range of African ancestry among these populations due to admixture of genetics. And in looking at that population, it was noted that for every 10% increase in genetically proven African ancestry, the serum creatinine rose by 0.02 units, suggesting there was a relationship with genetics and African ancestry in serum creatinine that may account for these differences in the serum creatinine in these population studies. Further in support of this study done in Europe, which looked at two populations that were essentially very, very similar from the standpoint of measured GFR, 302 Afro-Europeans and white Europeans. Measured GFRs were identical. Their age was very, very similar. The proportion of men and women were similar. Body surface area or their size was similar. However, serum creatinine was different, higher in Afro-Europeans. And also the excretion of creatinine, the filtration of creatinine was thereby different. And to some extent that there was a trend towards an increase in creatinine secretion in the Afro-Europeans. And this may be accounting for this different and actual blood number of serum creatinine, however, not a difference in actual GFR. So it goes back to the fact that creatinine is not a perfect or ideal measure of GFR, and there may be some genetic and environmental or combination of genetics and environmental issues associated with the difference in the serum creatinine that are not related to the GFR. In the full age spectrum or fast GFR commonly used in Europe, which has not been explored in the US, they have been able to relate serum creatinine with age, and based on sex across the age spectrum, which we obviously use a different GFR measure for children than we do for adults. They've been able to do this with an equation across the age spectrum with a normalization factor, which they call Q, to correct for these parameters, but also have found that Q differs by different regions. So the Italian Q is a little different from the German Q or some other countries. And that really supports the idea that there may be a combination of environmental and genetic factors that account for these differences in the relationship to serum creatinine and actual GFR. This needs to be further explored. We don't fully understand that, particularly among Americans. And of course, there's social determinants of health, and their influence on serum creatinine is not well known. These are issues that need further research to fully account for. So what I want to make really clear is this uncertainty of estimated GFR, and it's probably something that we as nephrologists have not emphasized. This is an example of a relationship of GFR to serum creatinine in a 50-year-old, in which the orange represents the race modified Black GFR, so to speak, and the blue represents if a 50-year-old were the equation were derived from a white individual. So this gives you the estimated GFR on in these dots and diamonds. So as you can see, there's not a whole lot of difference looking at there. What is remarkable is these bars that go across here. And this is the 95% confidence interval in that number. So this is the certainty that we have of that number. So for instance, this GFR of 130 could be anywhere from 90 to almost 180. And so there's more uncertainty in any given measure than this difference we're using or not using the race modifier. And that is a really key point that one must understand when you're thinking about estimating equations. So the real question is, what are the implications if we make changes? So if we remove the race modifier, there doesn't seem to be a change, that much of a difference with respect to the error involved in GFR. But when we think from a population level, removing this race coefficient is going to really decrease the GFR, because we will have less GFR amounts for Black people, therefore leading to a population number that is higher for CKD among Black individuals, and actually shifting Black individuals with CKD down. 30% of Black individuals would decrease to a lower stage, or would be reclassified to a more severe stage of chronic kidney disease, which is not a small matter. So the impact of this change on clinical decision making is really the crux of the situation, right? And where it becomes an issue is on these thresholds, or these borders of GFR, which are important clinically. So here is in red. This is basically a graph that compares the estimated to the measured. So if the measured and estimated were the same, you'd be on the 0 line. So anything under the 0 line means the estimating equation is underestimating the GFR, and above it would be an overestimate of the GFR. And as you see, this is the red indicates the error, and the measure GFR without the coefficient, blue indicating the addition of the race coefficient for an African-American individual. And so the clinical implications really lie in some of these threshold measures. So if a patient were, for instance, at this point, where if the race equation would consider this patient an adequate kidney donor, without the race coefficient, it would not consider that patient adequate as a donor candidate, which has clear implications. Over here, maybe the dose of medication may be adjusted downward to a low for the lower GFR, say for chemotherapy, which maybe have clear disadvantages to that patient if their actual GFR were higher, in which they would not get enough chemo. Or here, where along this range you would use a certain agent that is protective to the kidney, you may take the patients off that agent because you feel that they're in a harmful GFR, but they may benefit from that GFR. Or at lower ranges where transplantation would not be considered because their GFR is too high. So these are some of the issues that would come up when we consider a change in GFR based on these estimating equations, removal or inclusion of the race modifier. So one of the issues with removal is that these GFR reports were based on actual measurements of GFR, and the race modifier was there to create accuracy among self-reported Black individuals. Removing this has the potential to devalue those that data that was put in over 3,000 Black individuals, and create a standard that is basically using data obtained mainly from white individuals. And when you're considering that it may shift a number of people to more severe CKD stage who are African American, this is an issue that we have to think about in our consideration of removal of the race modifier. So for instance, let's look at both sides of this coin. If the GFR is more accurate with race removal, then potentially we may have earlier detection of kidney disease among African American individuals, or referral to transplantation may be sooner. However, if it's less accurate and causes an underestimation of GFR, we may be giving a diagnosis of CKD to patients who don't have a CKD, or by definition, maybe subjecting them to higher insurance and worry underdosing medications, and maybe even having premature referral to dialysis or transplantation. The potential approaches to reporting is that we really need to emphasize that these are estimates and creatinine is not perfect. And this needs to be conveyed to patients in a way that patients can understand the limitations of these equations and the serum creatinine. We also need to consider developing equations that treat everybody the same in terms of the development of the equations, so that we can use them in diverse populations and have very inclusive patients that they're derived from. And we need to really focus. I think the bottom line is we need to focus on research that uses better biomarkers that do not need race modifiers for applicable, so that they can be applicable to all individuals, multiracial individuals, individuals who have not been included as in these equations as well, the development of these equations. So the National Kidney Foundation, American Society of Nephrology have formed this task force, which you may have heard of, the NKF-ASN task force on reassessing the inclusion of race in diagnosis of kidney disease. I've been fortunate to be a member of this task force, and this task force includes a number of people with with wide expertise in pharmacology, in lab medicine, social determinants of health, health services research, NIH experience, as well as patients and others. The charge of this NKF was to examine the inclusion of the race or the race modifier in equations, recognize the implications if we decide to change that reporting, incorporate the concerns of patients and the public, which we have done, and especially marginalized individuals, ensure that eGFR provide an unbiased assessment of kidney function to the best of our ability at this time, and keep laboratories, clinicians, health professionals apprised of the long-term implications. So in our deliberations, we've looked at a lot of data. We've heard from 97 experts from 7 countries and a broad range of topics, from social issues to clinical to research. An interim report has been published by the American Society of Nephrology, by NKF, in the JASN and AJKD journals. And it shows, this interim report shows how we approach the problem and the issue, and the attributes that would be important in making our final recommendations. And this summer, we will be coming out with our formal recommendation, our final recommendations that will hopefully be successfully implemented. Where I think it is important to have as much accuracy in our data that applies to all individuals of all races and ethnicities. This is one of us. This issue is one of a small issue, a number of issues related to social determinants of health, from economic instability to social issues that lead to health disparities. And I think we should not get distracted in that fixing this eGFR issue is going to fix all our problems related to health disparities. It is just one small part of the bigger issue. So I think the take-home message here is that estimated GFR equations are imperfect. They're imperfect. They are derived from imperfect markers and therefore have a lot of uncertainty. That race is not a biological attribute. It is a social construct and is an imprecise measure of ancestry. There are inclusion or exclusion of race modifier does have clinical implications that need to be considered, and that really truly benefit from a better biomarker that is accurate and does not need or rely on measures or attributes, social attributes at all. So I thank you for allowing me to present. I would like to acknowledge the NKF-ASN task force, the community for giving us their feedback, from health professionals to patients, to medical students and other clinicians. As those quotes say, I think we need to be honest with ourselves in terms of the data and try to deliver as much equitable care as possible. And clearly, we need to have significant effort in addressing health disparities in CKD. And one of the ways we could do that is by improving and advancing our ability for all people, all Americans and all people worldwide, on the assessment of kidney function. Thank you.
Thank you, Crystal. We appreciate your insights. We realize that this is a very difficult and important topic. We appreciate what you and the task force are doing. And I also remember the pre-COVID days when you and I, along with others, spent time talking about issues for ASN and AAKP up on Capitol Hill. We look forward to getting back to those good old days.